My name's Andy Brand, and I'm the Interim Head of Inspection for Primary Medical Services in the East of England. I'm joined today by two of our National Professional Advisors here at CQC. We've got Dr. Tim Ballard and Dr. Janet Hall, and they're going to be explaining what the searches are, how we carry them out, and the sort of things we look at. Can we move on to the next slide, please? So, as well as Tim and Janet, we also have Sean Rick, who's a pharmacist specialist with CQC. We've got Sam Wallace from our provider engagement team, and we've got David Gwyther, who, as well as being our communication and engagement manager, will be producing today's webinar and basically holding the whole thing together. If we can move on, please. Thank you. So, before I hand over to Tim, as I said on the previous slide, today's session is going to focus on what the clinical searches are and the background to their development, how we physically carry them out, the information we look at as part of those searches, and then there'll be some time at the end for questions. Just to say at this point, unfortunately, we won't be able to go into any specifics about details on searches we've already done at practices. And I also need to remind you about Mythbuster 12 on our website, which gives some details around the searches that we do. So at this point, I'm going to hand over to Tim first, and then he's going to hand over to Janet.
Thanks, and thank you, Andy, and welcome everybody to this webinar. We've been working on these clinical searches prior to the pandemic, and I'll try and explain the context of how we've arrived where we are and the recent journey that we've been on. So the main reason to produce them was, having listened to individual providers and professional bodies, what we wanted to do was to support CQC's mission to improve our reliability and consistency of approach. So what we'd heard from some providers was that their experience of an inspection and the things that were looked at were different between two different practices. And we suspect that that was based on quite legitimate interests of individual inspectors and individual GP specialist advisors who supported inspections. But we really wanted to get to a more consistent place. So we started to develop these searches with that in mind. In order for them to be legitimate as well, we really wanted to focus on a shared view of quality, which is broadly related to the clinical risk management of patients in general practice. And Janet will go through each of those areas when I hand over to her. Can we have the next slide, please? So the shared view of quality, when we develop them, we check them out. We have regular meetings with the RCGP and with the BMA, and we got agreement with them that these were not intended to be an exhaustive list or an absolutely complete list of what practices needed to do for clinical governance, but were good exemplars of areas that should be covered. So the IT in general practice, as you all know, around about 95% of practices use either EMIS or System 1 as their clinical records, and we've built the searches around those. We've had a look at Vision. There are a small number of practices who use Vision, but we haven't been able to build an exactly comparable set of searches for Vision practices, for practices who use Vision, but it's really important that if any of you are using Vision, that what we aim to do is to cover exactly the same ground or as near to the same ground and topics that we cover for other practices using the downloadable searches as well. Next slide, please. So we were developing these searches, as I say, to try and improve the reliability and consistency. And then along came the pandemic. And the pandemic affected primary care, as we all know, with an immediate cessation to people being able to walk into practices based on NHS England guidance, and CQC, in responding to the impact of the pandemic, moved away from a time-based programme of inspections to focus on a risk-based approach, so identifying practices where we were getting signals that patients were at risk. Move to the next slide, please. So the benefits for us for an off-site assessment, we developed a process where we could have a link for our specialist advisors to be able to link with an individual practice's clinical system, always with consent. So we always get consent from the practice to actually do this. But then the GP specialist advisor can actually carry out a remote inspection. So instead of having to cross the threshold and be under the feet of a practice, we can do it essentially what feels like to be in the background, and that had clear benefits for us and for general practice as we saw it. So first of all, there was the reduced risk of transmission of COVID-19, either from our inspection teams to our inspection teams, and there was also the reduced opportunity cost, and that again worked for individual practices, because we felt that the experience would likely result in a feeling of less burden for practices, and not having us on site would be less of a distraction for practices who were battling away to provide important clinical services to their patients during the pandemic. And importantly as well, especially for me involved in this work, there was the reduced environmental impact of not moving inspectors and specialist advisors around the country to carry out inspections. Next slide, please. And over to Janet.
Thanks very much, Tim, and welcome everybody. So, as Tim said, the searches are based on the current national guidance and have the approval of both the BMA and the RCGP. They've been specifically designed to identify potential high risk rather than evidence of good practice. Practices are expected to have their own clinical governance systems and processes in place to ensure that patients are receiving monitoring and having treatment in line with national guidance. And they should not rely on these searches alone. Otherwise, this may lead to potential patient harm due to delay in treatment or monitoring. Guidance has been produced for the inspection teams to support these searches that's based on the BNF information, NICE guidance, MHRA alerts, and standard templates have been developed to ensure high quality, consistent, relevant evidence is collected by the inspection team, particularly the GP specialist advisor, otherwise known as a SPA. The searches have been adapted to take into account the changing guidance and more lenient parameters and monitoring intervals for those patients where it was appropriate to do so during the COVID pandemic and the recent blood bottle shortage. The clinical searches identify groups of patients who fulfill the specified search criteria, indicating that they are at potentially high risk and where monitoring may not have been carried out in line with guidance, but by themselves they don't provide sufficient detail on their own, without more detailed review of the actual clinical records and consultations that support these. The specialist advisor selects one search that is deemed to identify the highest risk to patients from each of the categories that I will go through shortly. They then review 5 individual patient records chosen at random to determine if there is a risk to patients, what that level of risk is, what the potential implications are for the patient, and take into account the context and actions already taken by the provider, which might mitigate the level of risk to patients. The specialist advisor then makes a judgment based on the evidence in the records and the level of risk to the patients, which might be affected by multiple factors. Some of these factors that we take into account include: has the practice got robust systems and processes in place to ensure patients are identified and called or recalled for monitoring and review? And are these being proactively managed? Are there safeguards to ensure patients are identified if monitoring is overdue? For example, limits on quantities of prescriptions issued, medication review dates set at shorter intervals, or limited numbers of issues of prescriptions. How long is it since the patient last had their monitoring done, and has it been done regularly prior to this date? Were previous test results normal? And if not, was action taken regarding abnormal results? Has monitoring been done elsewhere and not coded, for example, on ICE systems or in hospital letters? Does the practice make an entry in the clinical record to state that monitoring has been checked prior to issuing a medicine? Does the practice reduce the quantity of medicine prescribed if monitoring is overdue? And has the practice tried to contact the patient and arrange for the tests? And if so, how many times have they done this? What method have they used, for example? Which patient factors are present that affect the risk? For example, the patient's age, their other comorbidities, other medicines that are prescribed that might interact with the current drug, the time since the monitoring. And has a medication review been coded and not identified that monitoring was actually overdue at that time? Specific GP evidence templates have been developed to ensure consistent evidence collection and enable the specialist advisors to collate all the information required. These also assist the inspector to interpret the data the SPA's collected, and they're asked to document if there's any evidence of potential or actual harm to patients from the notes that they've reviewed. The aims of the searches, as well as identifying and highlighting potential risk to patients, is to promote quality improvement and drive safer, more effective delivery of care and treatment. The next slide, please. So the clinical searches are used in a variety of settings, not just in the primary medical services inspections, which include GP surgeries, but also in some quality assurance sampling that CQC undertakes. They cover a range of clinical treatment, monitoring and prescribing searches, identification of potential misdiagnoses, response by practices to safety alerts, and the implementation of national guidance. And we'll come on to talk about each search in more detail shortly. The remote searches have also been used on different inspections. For example, we look at DNA CPR records to see whether these have been completed correctly. We've got searches to look at access, and we've got searches for a variety of other areas, such as vaccinations, screening programs, safeguarding, care planning, and other specific prescribing indicators. The GP record searches have also been used in other areas, for example, the provider collaboration reviews, to demonstrate how providers have worked together or not across the interfaces of care, and ensuring safe and effective care and treatment have been delivered during the pandemic in each of the areas of focus. And so far, these have included cancer care, learning disability, and children and young people with mental health issues. The clinical searches have also been used in the DNA CPR thematic piece of work, and subsequently the RCGP Marie Curie lead has approached us to ask if they can adopt our evidence template as a resource for practices working towards the Daffodil standards. The searches have also been used in other areas within CQC, for example, in the inspection of prison services and in defence medical services inspections, including allowing us to inspect premises overseas or in restricted areas. Next slide, please. So I'm going to go through now each of the different categories of searches that we look at. I'm going to go through these in some detail because I suspect that's what you're all wanting to know. As Andy's already mentioned, much of this information is already included in the mythbuster, but I'll hopefully give you some detail so that you're able to understand how and why the searches have been selected. So first of all, we'll look at DMARDs. This looks at 3 different DMARD medications. It doesn't currently include biological therapies. So it looks at azathioprine, leflunomide and methotrexate. And for each of these drugs, it identifies patients who've had these medicines prescribed in the last 6 months and haven't had monitoring done in the last 6 months. Now, the monitoring that we look at is the blood test monitoring, and for leflunomide, also the weight and blood pressure monitoring. As you'll all be aware, the NICE guidance and BNF suggest that monitoring and SPS guidance suggests that monitoring should be done much more frequently than every 6 months, usually every 2 to 3 months, especially if people have other risk factors. During the COVID pandemic, this monitoring interval could be extended to 6 months, providing that patients didn't have any additional risk factors. But this is why we're calling them at-risk searches. They're not there to be able to support good governance and the regular routine monitoring, which should be occurring every 3 months. If we look at the next category of high-risk drugs, this looks at the monitoring of patients on ACE inhibitors or angiotensin receptor blockers, especially in combination with spironolactone or eplenorone. And it looks to see whether patients have had use and ease done. So for those taking combinations of ACE inhibitors or ARBs and spironolactone, we look to see whether people have had use and ease done within the last 6 months. And for those just taking a single ACE inhibitor or ARB, we look to see those who haven't had a U&E done in the last 18 months. Again, these intervals are longer than would normally be expected for routine monitoring. We also look at patients who are prescribed amiodarone to check those who've had that prescribed in the last 6 months and who haven't had liver function tests and thyroid function tests done in the last 6 months. And then we have a whole suite of searches looking at DOAC medicines. Over the last few months, particularly during the pandemic, there's been an increase in transferring patients from warfarin to DOACs. And these drugs, although they don't require the regular monitoring with INR, still do require regular monitoring in the form of other blood tests. So one of the searches that we do is to check that people are having their creatinine clearance level calculated. This is more than just doing the U&E, but a separate calculation to calculate the creatinine clearance is what is required in order to ensure that patients are on the correct dose and having the correct monitoring interval. So we do searches to find those who've never had a creatinine clearance level checked, those that haven't had it calculated in the last year, and then depending on the level of creatinine clearance, those who haven't had use and ease done within the specified interval. We also look to check those patients who haven't had a full blood count or LFT done in the last 15 months, and we identify those who are on a DOAC who have had a reduced hemoglobin of less than 9 in the last either 12 months or 2 years. Other drugs that we look at include lithium, those who haven't had monitoring done according to the BNF guidance in the last 6 to 9 months. That's 6 months for the lithium level and 9 months for the U&E and other tests. And we look at patients who are prescribed mirabegron, who should be having regular blood pressure monitoring, to find those who haven't had a blood pressure check in the last 12 months. We also look at patients prescribed warfarin to check that they've also up to date with their INR monitoring. Looking at the next category of MHRA alerts, we have a mixture of alerts here. Some are single drug alerts and some are combination drugs. So we again have got some searches relating to ACE inhibitors and spironolactone and eplerenone, looking to check that they've had use and ease done. We're looking at citalopram, especially prescribed to those over the age of 65, to make sure that patients aren't prescribed more than 40 milligrams in accordance with the MHRA alert that suggested that patients over 65 shouldn't be prescribed more than 20 milligrams due to the adverse cardiac effects. We also look at patients prescribed combinations of clopidogrel and omeprazole in the last 6 months to identify whether these patients are still on the combination, as omeprazole has been shown to reduce the effectiveness of clopidogrel and potentially increase the risk of heart attacks and strokes. We look at those patients on a DOAC who have a mechanical cardiac valve to check that the DOAC has been prescribed appropriately, and identify those patients who've been prescribed febuxostat who have a history of cardiovascular disease, as an MHRA alert suggested that patients with a significant history of cardiovascular disease shouldn't generally be prescribed this drug. We look to identify those who've recently been started on a fentanyl patch to make sure that these haven't been prescribed to an opiate naive person. And then another combination drug is the simvastatin and amlodipine. Again, simvastatin 40 milligrams shouldn't be prescribed in combination with amlodipine due to the muscular effects. And we look to check whether this has been happening. And then there are a series of searches where we look for cohorts of patients where patients should have been advised of potential risks in taking the medicine and potentially had action taken. So hydrochlorothiazide and the increased risk of skin cancer, we're looking to check that patients have been informed. And also the SGLT2 inhibitors for diabetic patients to make sure that they're aware of the potential risk of Fournier's gangrene if they get any ulceration or soreness, particularly in the groin. And then we have the teratogenic drugs, which includes valproate, carbimazole, and modafinil, for those where it's prescribed to patients of childbearing age to make sure that they have high quality contraception in place and pregnancy prevention plans, etc. On to the next slide, please. The next group of medicines is looking for potential misdiagnoses. So we are looking for potential misdiagnosis of chronic kidney disease, stage 3 and below, and also potential misdiagnosis of diabetes. As I've mentioned previously, it's important with all of these searches that we look at the records behind the initial results, because sometimes when we look at the records, the diagnosis may not have been of diabetes. The patient may have pre-diabetes and may only have had the readings of HbA1c separated by several normal readings in between, and the same for the GFR. Medicines usage, we're looking at drugs where there's either limited effectiveness or they shouldn't be not recommended to be prescribed on a regular basis, or where there needs to be close control of what's been prescribed. So we're looking at benzodiazepines and Z drugs that have been prescribed on 10 or more occasions over the last year, suggesting repeated prescriptions of a medicine that isn't recommended to be prescribed on a long-term basis. Prescriptions of gabapentin or pregabalin in the last 6 months who haven't had a medication review in the last 12 months. And then patients who have been prescribed over 12 short-acting beta agonists, such as Ventolin, in the last 12 months, who don't have COPD, but potentially have asthma or no diagnosis at all. And this is related to check that patients' asthma is well controlled and that they're having regular reviews of their asthma if they're using more short-acting beta agonists than is recommended. The medication review search looks to identify those people who've been coded as having a medication review in the last 3 months, to check on the quality of that medication review, to ensure that it's more than just a code, to ensure that a review of the medicines that the patient's taking and their conditions has been undertaken, and to make sure that monitoring is up to date and there aren't any contraindications and that all medicines are aligned. And then more recently, we've added in some long-term condition searches to identify patients who are at high risk. This isn't a substitute for QOF, but during the pandemic, we would have hoped and expected that practices would have continued to monitor those patients with chronic conditions who are at higher risk. So the first search is identifying asthmatic patients, not those with COPD, who have had 2 courses of oral steroids prescribed in the last 12 months. And what we're looking for here is to check that patients have had monitoring done and had regular asthma reviews and their treatment scaled up and stepped up if appropriate. We're looking for people who have been coded as having CKD 4 or 5 to check that they've had monitoring of blood pressure and use and ease in the last 18 months. And we're looking for patients who are already coded as having diabetic retinopathy and who have a latest HbA1c of greater than 74 to suggest that their control may not be optimized, to ensure that they have been seen and reviewed and treatment adjusted if necessary. And then we're looking for those with hypothyroidism who are prescribed thyroxine who haven't had a TSH monitoring in the last 18 months. On to the next slide, please. So what did we find? The results, so these are examples of some of the searches on a System 1 basis, just to show you how the searches actually look when they come out. And then we go behind into the patient records after we've got these cohorts identified. And the next slide, please, David. And again, this is looking at the next category. And the next slide, please, David. So what did we find? As I've said, the results have been very variable. Some practices, despite the pandemic, have been doing an exceptional job to keep on top of all of their prescribing, their care and treatment and their review of patients. And have got robust systems of call and recall to ensure that patients have been able to have their monitoring throughout the pandemic. However, we have found some areas of concern. And I'm going to just go through a few of these areas as a signpost so that you can reflect on your own practice and see whether there's anything that you need to do. So the first area is the monitoring of high-risk drugs and particularly DMARDs. And I found patients haven't necessarily had the monitoring that they require and that it's not been done in line with national guidance, which has sometimes exposed patients to serious, sometimes life-threatening complications. For example, we've found that medicines have been prescribed when monitoring is considerably out of date, and there's been no evidence when we've checked in the records to show that the prescriber has checked that monitoring has been done and is up to date before issuing the drug from a repeat prescription screen. We've also identified that DMARD medicines have been authorised for up to 12 months, and there's been no restriction on the number of issues, allowing receptionists to keep issuing the medicine without having to have the monitoring checked, and therefore a fail-safe has been overridden. With regard to long-term conditions, we've found that some patients haven't been diagnosed with diabetes or CKD when they should have been, which has meant that they're not receiving the appropriate management or monitoring or review or screening that could result in some long-term, life-changing, irreversible complications. For example, we found that patients with a past HbA1c levels in the diabetic range haven't been coded as having diabetes and therefore haven't been referred for screening or regular monitoring or lifestyle advice. On review of a sample of 10 practices, we identified 102 patients with repeated raised HbA1cs indicative of diabetes who hadn't been coded as such, meaning that they hadn't had the appropriate recall and were therefore at an increased risk of complications such as retinopathy or peripheral neuropathy. We found evidence of medicines being prescribed alone or in combination contrary to the MHRA safety advice, which could potentially lead to fatal drug interactions, significant illness or serious complications, for example, to unborn children. I've already mentioned issues that we have identified with DOACs, but on a review of the DOAC prescribing through our pilot, we have identified that 30 practices inspected, in 30 practices that we inspected during the pilot process, we found that 59% of patients hadn't had their creatinine clearance documented in the previous 12 months, and a similar proportion had never had their creatinine clearance documented. This means that the practices couldn't assure us that there was sufficient information available to ensure the correct dosing of the DOAC to reduce the risk of bleeding or risk of clot formation leading to serious complications for the patient. We've also seen examples of excessive prescriptions of medicines which are addictive, have limited clinical value and indicate poor control of underlying conditions. So for example, I've mentioned the use of short-acting beta agonists, and in a review of 10 practices, we identified that 90 patients were receiving more than 12 short-acting beta agonists in the last 12 months. And in one practice that I inspected, there were over 30, one patient had had over 30 inhalers issued and no review of their asthma. We also have identified inadequate medication reviews or long-term condition management, which places the patient at risk. For example, we've seen examples where the medication review has been coded, but there's just the code. There's no evidence of any review being done and no free text to support that review. We've found codes that have been added by non-clinical staff, for example, HCAs or receptionists. We've seen lots of code being added late at night within a few minutes of each other, which have obviously been added as a batch process rather than an individual medication review with a patient. And we've seen examples where medicines that are contraindicated in combination or haven't got up-to-date monitoring have continued to be prescribed despite a medication review being coded. Other areas where we've identified concerns are that during the remote check of practices and the searches is that DNA CPR forms have been inappropriately or inaccurately completed. We've seen evidence of poor record keeping and consultation documentation, of staff working outside their competencies and scope of practice, of inadequate alerts and coding to identify vulnerable patients, and backlogs and delays in the management of clinical correspondence and reporting and filing of laboratory results. But as I've said, we've also seen lots of evidence of good practice as well, and practices taking action in response to these searches. From the inspections where we've used these searches, we've received positive feedback regarding the new approach and particularly the use of the searches. And practices have been really appreciative of the information contained within the searches and in general have responded positively to address any areas of concern. So the next slide, please. So from a CQC perspective, we've identified three main areas of benefit from using these searches and taking the online approach. First of all, these searches have helped us to identify significant clinical risk that may not otherwise have been identified during the inspections that previously CQC might have undertaken. We've identified improved consistency because the searches are the same that are used on every system, whether it's EMIS or System 1, and we try to duplicate them on inspection in the vision practices. And they've also provided us with strong evidence to support enforcement in the few occasions where that's been needed. Next slide, please. So what are the benefits and the limitations of the searches and the online process? So there are many benefits, as Tim mentioned a few briefly at the start. The searches now allow us to focus on clinical safety and effectiveness and the quality of patient care, rather than just the systems and the processes. It provides us with robust, high quality evidence and encourages a consistent approach with quantifiable data, which is outcomes based. It helps us to identify potential areas of risk for patients and to promote quality improvement. And it can also be used to help us monitor improvement in providers if issues have been identified. It helps us to effectively support enforcement, and it's useful for quality assurance of some of our monitoring. It also helps us to support cross-sector working within CQC by doing pathway tracking and using the searches in other situations, for example, the provider collaboration reviews. And the system is transferable to other parts of the NHS and clinical systems, for example, when we've used it in the prison service and in the Defence Medical Services inspections. It's also cost effective, it's environmentally sound when we do it online, and it's adaptable to lots of settings. There are a few limitations. We do need to review the patient records behind the searches. We cannot take the searches at face value for some of the reasons mentioned earlier, to ensure that we take into account actions that the practice has done to mitigate any potential risk. We're currently only identifying high-risk patient groups, although these searches could easily be adapted to identify very high-quality care rather than just the risk-based. We have to rely on providers accepting and approving our remote access. If a provider declines remote access, then we will come and do the searches on site. And also, obviously, there's a cost to the CQC in that they need to buy equipment for the SPAs to use, and the specialist advisors need to have a reasonable level of IT literacy and additional training in order to do this. So that's the finish of my sort of section. I just want to remind you as a sort of health warning that these searches are based on identifying potential risk to patients. And again, as I said earlier, shouldn't be used by practices as the sole means of identifying patients who require monitoring. We would expect all providers to have their own governance and monitoring systems and processes in place, which are based on the national guidance and the regulatory requirements, to ensure that patients receive the monitoring they require at the correct interval and are prescribed medicines appropriately and receive care and treatment in line with national guidance. So I hope that's helped you to understand the searches that we're doing, and I'll hand over now to Tim. Thank you.
Thanks ever so much, Janet. So there's just a couple of areas that I want to just discuss and bring to your attention at the moment. I want to echo what Janet's just said about the searches not being, they were never designed and shouldn't be taken as an alternative to practice's own clinical governance systems to ensure safe care. It's really important. If there's one take-home message from the whole of the webinar, I think it's that we would both, as national professional advisors, like to reinforce. We've wanted to be really transparent. This webinar is an example of that. But right at the beginning, if you cast your mind back to Andy's introduction, he mentioned Mythbuster 12. So I'm sure many of you will be aware of the Mythbusters. They're a really useful distillation of advice and the way that CQC approaches various areas. I think there's around 100 now, but it's Mythbuster number 12, which has been continually modified while we've produced the searches and while we have developed them and moved forward. And you'll find really useful information there which details some of the areas that Janet's been talking about, though by necessity not in quite as much detail. We've also heard from the profession that even more transparency would be helpful. at the outset, when we produced the codes, we had long discussions internally about whether we could actually make them sort of free to air through our website, and there were significant disadvantages to doing that. But what we are doing currently is working with the main system providers, with EMIS and System 1, to look at how we might be able to get them onto their national libraries, so that they will be available to all practices using those two systems across the whole of the country. We can't say it's going to happen yet. We're still in negotiation with them, but it's our desire to make them available to everyone. There's also a big piece of work going on. The disadvantage of the searches as they are at the moment, despite them being remote and a definite decrease in the opportunity cost that we've spoken about during the webinar, there is still a need to directly interact with a practice, which is very labour intensive. And what we are looking at is trying to identify areas of practice performance, some of which will be similar to the searches, to identify potential outliers for clinical risk, but where identified, it would still result in a need to understand the context and the individual patient circumstances, rather than basing decisions directly and purely only on the use of sort of unqualified data. Thanks, Andy. Back to you for the questions.
Lovely, thanks so much. So I think as we've been running through the presentation, our colleagues have been collating the questions that have been coming in and dividing them up into sort of main topics. So I don't know if we've got anything question-wise.
Hi, Andy, it's Sam here. Yeah, we've got loads of really great questions from attendees, which is fantastic. I think Tim has really helpfully answered one of the main questions, which is about how might providers get their hands on the actual searches themselves, so they can use them in part, you know, through their work and on their system. So it's really good to hear that that work is going on with the main system providers out there. We've also had a few questions, just wanted a bit more detail about when we started using this approach, and also when we do go and use it on a inspection, do providers know in advance? Do we have a conversation with them? Just be good to get a bit of detail around that.
Okay, yeah. So we started a piloted approach during the pandemic, actually, with a number of practices, and it was during the time when we were looking to follow up on practices that had been previously rated inadequate. There was significant risk there, or practices in special measures, but obviously due to restrictions in the pandemic, we weren't able to physically get out and cross the threshold, but we needed to be in a position where we could respond to risk. So that's when we kind of started piloting the process, and then we kind of we took the learning from that pilot and then refined it, and we've rolled this out kind of in the interim between the height of the pandemic and now, really. So it's now part of our routine inspection activity. I suppose officially you'd probably say from the 1st of April. From the 1st of April this year, it's become part of routine inspection activity. When we use them on inspection, yes, of course, we contact the practice in advance. We always have the 2-week announcement period, unless there's a definite reason why we'd need to go in unannounced. But as a usual inspection, we'll give 2 weeks notice. In practice, that turns out to be slightly more often, because we need to get the arrangements made with the practice. As I think Tim and Janet both said, we need to do, when we're doing remote or off-site clinical searches, we do them in with the practice consent. So we obviously need to set that up in advance, so that the practice does have advanced notice that we're going in, and then we're very keen that the practice will actually sign the SPART out of the system once they finish their search as well. So you kind of know when we're going in, and you know when we've come out as well. I don't know if Tim or Janet, I see Tim's got his hand up.
Yeah, just one thing about I agree with all of that, Andy. I think that was really clear and really helpful. There's just one area that might not be clear to delegates and colleagues on the line, which is that when we finish doing the searches, we leave them on the practice system. and so it will be there for practices to use how they see fit, and were that to share with other colleagues and practices, then that's in the gift of the individual practice. We certainly can't, we're not going to encourage that, but if that were to happen, as I say, the searches become the property of individual practices where we leave them on.
Thanks, Tim.
Great, thanks both. We've also had a few questions about how this work might interact with QOF and various searches that might take place because of QOF assessments, etc. I wonder if we could say something about that.
Yeah, I can introduce this. So as you'll be aware, that we've stopped using QOF as part of our routine inspection activity from the 1st of October because the data had become unreliable because of the COVID pandemic, and so we've actually replaced that mode of looking at how practices are meeting the needs of people on long-term conditions. We've replaced them with a set of searches. I don't know if Tim or Janet could say a little bit more about those specific searches that we've replaced them with.
Yeah, so the searches that we've developed aren't a sort of equal swap with QOF. What we have done is identified some areas of potential high risk to patients who have got long-term conditions with complications or had significant deterioration, suggesting, for example, the asthma patients who might need recurrent courses of oral steroids, those with diabetic retinopathy who've got very high HbA1cs, in order to check that practices have been reviewing particularly the high risk patients and adapting their treatment and their care in line with that. Obviously, the ideal would be that all patients with long-term conditions have regular monitoring and review, but we realised during the pandemic this was more difficult, but we would hope that practices would have prioritised those particularly at higher risk, which is why we've developed these particular searches.
And yeah, Tim's got his hand up as well. Thank you.
Yeah, thanks, Janet. That's really clear. And just to add to that, along with all the main searches that Janet talked about, the long-term condition searches and their content have been shared with the college and the BMA.
Lovely, thanks both. Great, and we've also got some questions about how we might adapt the searches or look to adapt what they measure based on any changes to national best practice guidance around prescribing medications.
Yeah, so I'll come in on that one. We have a regular working group with our pharmacy colleagues, myself and Tim, and inspection colleagues, and the policy team, where we're reviewing national guidance and data, and we'll adapt the searches should we need to, based on new MHRA alerts coming out, changes to guidance with QOF, changes to NICE guidance or BNF guidance. So we are constantly reviewing that. We don't want to be changing the searches very, very regularly because that doesn't help anybody. So these are risk-based searches, as we've mentioned several times before. So we're identifying those at high risk, but we will add to the searches or remove other areas as the guidance changes.
And Tim's got his hand up as well.
It's just to pick up on the issue around QOF. So what the approach is that, as Janet quite rightly said, the pandemic and then the blood bottle shortage significantly impacted on practices' abilities to carry on routine monitoring in the way that it had been done. There was the special pharmacy guidance, the SPS guidance, which gave the longer intervals, but we did want to look at specifically at cohorts of patients who appear to have been at particularly high risk of complications and at risk with their management. And again, it's to identify a cohort of patients to then look at their results, not to say that it's wrong to give people, say, 2 courses of really need it, and it's a really important. So again, the message is that we do look under the bonnet and have a clear look at it. The other the other issue for clarification is around QoF. So whilst the Commission has taken the decision not to use QoF routinely in care, in our regulatory processes, there may well be occasions with follow-up inspections where a significant problem was encountered in relation to areas of clinical performance reflected by QoF, and it will be quite reasonable for an inspector with their SPA, their professional advisor, to follow up those areas. So they're not completely out of bounds, but we're not routinely using QoF data because of the way that it was suspended as a payment mechanism for the profession.
Lovely, thanks for a bit of clarification, Tim. Sam?
Great, thanks. We've had a few questions just wanting a bit of clarification about how this process fits in with our monthly monitoring of services. So I think just a bit of reassurance about when practices might experience this.
Yeah, thank you. Yeah, thank you. So the monthly monitoring is an automated process that's kind of run in the background for lower risk services. It's something that doesn't routinely involve us going and doing clinical searches. As I said previously, anytime we're going into a practice clinical system, doing it off-site, we'll be in touch with the practice in advance to let them know we're doing it. There is some activity that we're carrying out. I think Janet kind of referenced it before about some sampling activity. That does involve some clinical searches, but again, those are we contact the practice in advance and we gain consent before we do anything to do it. But the routine monthly monitoring that happens doesn't involve clinical searches on its own. And Tim?
Yeah, thanks. So just to build on that, when I spoke in one of the slides about developing a data strategy to monitor data passively, that's what will actually eventually contribute to regular monitoring and the monthly reviews, but we're not there at the moment.
Lovely, thanks, Tim.
Great, thanks both. We've also had a few questions about how we might take into account the difficulties of patient records moving between services. So, for example, where somebody might also be under the care of a hospital, but the records of what the hospital is doing for that patient might not move to the GP that quickly, and our searches might not pick up the most up-to-date, accurate information. Do we take that into account?
Lovely. I see Janet had a hand up for that one.
Yeah, so absolutely. So the searches, the sort of high level values of the searches give us an indication, but they don't give us the whole answer, and that's why it's really important that we do the records reviews behind those searches and do the random sampling of patients. So we will look at a number of things to see what is happening. So, for example, if a search suggests that 3 out of 5 patients haven't had methotrexate monitoring doing, we will have a look at those 3 patients and see whether there are any mitigating factors. So when we look in the records, it might be that actually the results are in a hospital letter, that the GP prescribing or issuing the prescription for the methotrexate has written something in the clinical records to say monitoring up to date, see hospital letter. It may well be that the information is on the electronic hospital blood result, ICE or TQuest or whatever it is in your area, which we can't pick up in our search because it's not coded within the record, but is available. And if the practice has contacted the patient 3 or 4 times to ask them to come in, and if they haven't come in, has reduced down the quantity of the medication or put it onto an acute, or done some form of risk assessment or brief risk assessment and made some comment in the note, that will all be taken into consideration because that obviously reduces the risk to the patient. If, however, we find that 3 out of those 5 patients, when we look in the records, the GP has just continued to prescribe the medicine, the monitoring is years out of date, nobody has made any recollection to that, they've got a medication review code that says a medication review has been done, but there's no evidence of a code, and clearly they haven't looked at the monitoring, then that is much more risky for the patient. So there's no one size fits all, but the specialist advisors are trained to look at all of these different factors, to take them all into account, and then based on that particular situation for that one patient, we'll make a judgment about whether there's any risk to the patient or there isn't, and what that potential risk might be. And that will be the same process for all of the different searches on the red notes reviews.
Thanks, Janet. I see Tim's got his hand up as well.
Yeah, thanks, Janet. That was really helpful. So Janet and I are both in clinical practice, and we understand that it can be really difficult and challenging to get some patients to come in for the medication reviews. And again, the take-home message, what we don't want to see is unintended consequences from this, or a message that goes out that CQC says that you should never prescribe medicines for people who are overdue, because that's not what we're saying at all. What we're saying is that a practice should be able to demonstrate by us looking in the clinical record that they're aware of the problem, and a decision might be made that it's in the patient's best interest to continue to prescribe in the absence of monitoring. And that would demonstrate that the practice is endeavouring to get the monitoring done, but that someone's taken clinical ownership of the risk as well, or to shorten the duration, or to even stop it under certain circumstances, but a clinical decision and ownership of the problem being clearly taken.
Great, thanks all. And we also have a question just asking for a bit of clarification around whether searches in individual practices will also be looking at activity delivered by people employed under the R scheme.
So yes, where say a practice pharmacist or a PCN pharmacist is delivering medication reviews on behalf of the practice, even though they're not directly employed by the practice, they're carrying out the regulated activity on behalf of their practice. And yes, we would definitely be looking at that, including the quality of the service that's actually being delivered.
So thanks, Tim. Yeah, my mouse just froze at a really inopportune moment then. Just come back to that previous point. I just want to really underline what Tim had said about data and the searches. Like all the data that we use, the searches in and of themselves are a starting point for discussion, just like we would use QOF previously, or I would use patient survey data. So we do the analysis of the searches, but we also, really importantly, we talk to the practice to find out what's actually going on behind that data. That's what I was desperately trying to get off mute to say, but unfortunately it froze. Sorry, Sam.
Okay, thanks, Andy. So I think there was also quite a few questions about how we'll take into consideration the local context that some practices are operating in. I think in particular where they're getting direction from CCGs around prescribing and use of medication, or whether there may be things like local shortages of blood bottles, etc., and that kind of thing.
Yeah, thank you. I mean, we do obviously consider the local context of what's going on. Not to say that we would kind of make allowances for poor care for being in a particular area, but we do. We definitely, as part of the whole decision making, and particularly when it comes down to kind of enforcement activity, we would always take into account the local situation and the directions that have been given to a practice. So yeah, have no fear.
Thanks, Andy. There was also some questions about how widely we're using this approach. So are we also going to be using it for independent providers of general practice services and for online or digital providers of GP services? I
think it's fair to say we're not using them for independent health. I don't know a particular reason for that. I don't know, Janet or Tim.
Yeah, so the technology that we use through the VPN token, it is possible to connect to any sort of remote server that uses the HSC N3 network. At the moment, we're currently only got specialist advisors and the feasibility to do it through EMIS and System 1, but it can be used where those systems are used in any setting. So if a hospital uses EMIS and System 1, we could do inspections in those areas across different settings. If a private independent health happened to use one of those systems, we could do it in that setting. However, most of the independent health providers use different clinical systems. Sometimes they're just paper-based, sometimes they do use computer systems, but may not be one of the standard ones that we're used to using. And therefore, we haven't got a series of searches that we can use remotely to access the system to do that. Often with independent health, the service is a very sort of narrow range of provision. And searches may be built by the specialist advisor on the site in order to find out particular areas. that are relevant to that provider. But at the moment, it's just been done in the NHS GP providers, and we are looking to see how we can adapt this to do Adastra and out of hours providers, but currently it's just in hours NHS general practice.
Really well articulated answer. Thank you, Janet. Better than I could have done. See Tim sitting there with his hand up.
Yeah,
We've probably got about a minute left.
Yeah, it won't take long. So thanks, Janet. I think that was really clear. Just to build on that, I think it's a great question about the online providers. And whilst the online providers, as example, as identified with organisations such as Livy and Push Doctor, who are there supporting individual practices and their clinical care, and whilst they are carrying out a regulated activity while they support those patients, they don't have the overall clinical governance to look at the areas of risk management that the searches look at. So that's why we don't run them there either.
Brilliant. Thanks for that, Tim. That's been really, really interesting, but we do need to start wrapping up now. So I wonder, David, can we move on to the next slide, please? So here are some ways you can stay up to date with developments of CQC. So the first one on there's Citizen Lab, and that's basically our digital engagement tool, which you can sign up to by following the link on the slide there. Then there's the provider bulletin and the blogs, and again, you've got links to those on the slide. Obviously, as you'd expect, there's Twitter, and don't forget the podcast, which you can catch up on via CQC Connect. As I said, the links to all those are going to be available on this slide, and we're going to make the slides from today's session available. We're going to publish a recording from today on YouTube, and we'll share the slides to our provider bulletin. I'm going to give another plug for Mythbuster 12 on our website. We've said it a few times, but it's Mythbuster 12 on our website, and that's about access to medical records during inspections, and that gives more information about the searches we've been talking about today. So all that really remains for me to do is to say a massive thank you to Tim and to Janet for running through the information on clinical searches today. I hope you found it useful. I certainly did. I learned some stuff today as well. I also need to say thank you to Sean, Sam and David for their support in pulling the questions together and for keeping the session moving. And obviously thanks to you all for taking the time to join us today. Thank you very much.